Good afternoon, everyone, and welcome to our CDPH and CMA virtual Grand Rounds, Emerging Public Health Issues. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session on gender-affirming care. We've all seen the topic of gender-affirming care take the spotlight in the national scene. The media often highlights the most polarizing views of the issue, posing those who argue that gender-affirming care is vital and save lives against those who describe the care as dangerous and even as child abuse. And many states are in the process of placing restrictions on physicians' ability to provide gender-affirming care. As we try to make sense of this polarization using data and science, we're so grateful to have Jason Tesker from the California Department of Public Health discuss the landscape of gender-affirming care in California. First, however, we'll welcome back one of our usual guests, Dr. Erica Pond's colleague, Dr. James.
Right, thank you very much.
You'll be sent a survey after completing the webinar where you can attest to our attendance. And upon completion of the survey, we'll send out our certificates. I think you briefly saw our speakers' disclosures, and you can view those in the slides, which are available now through your webinar. And now we will start off with Dr. James Watt, who is the Assistant Deputy Director of the California Department of Public Health, Center of Infectious Diseases. Thanks so much for being here, Dr. Watt.
Thank you very much. Glad to be here. Let's see, can we pull up the first slide? So I have three quick updates for you today. I'm going to talk briefly about trends in COVID-19, then give you an update on H5N1 avian influenza, and then finally I will share some information on a CDC health advisory on possible shortages of stimulant medication for treatment of attention deficit hyperactivity disorder, or ADHD. But starting out first with COVID-19, we have been seeing increasing trends in indicators of viral circulation. You can see this on the top bar looking at test positivity. This has been increasing for the last 2 months and has reached levels similar to the winter peak in January 2024. Fortunately, COVID-19 mortality remains at a relatively low level, although we have seen some increase over the last month, and mortality trends do tend to lag behind test positivity. Next slide, please. Looking at wastewater, we can see that the trends are also in parallel with test positivity. So we've been seeing increases in wastewater concentrations of SARS-CoV-2 over the last 2 months, and levels are particularly high in the Bay Area. That's the panel there labeled Abajo, and the greater Sacramento regions. And in those two regions, we've also seen levels in wastewater similar to those in the December 2023 peak. The bottom line is that COVID-19 is circulating in California. Please remind your patients to stay home if they're sick, to test if appropriate, consider treatment for high-risk persons with COVID-19, and encourage people to stay up to date on their vaccinations. Next slide, please. With regard to SARS-CoV-2 variants, we are seeing several strains circulating. The most common in California right now is the KP3 strain, which represents about half of the specimens. KP3 and the other circulating strains are all closely related to the JN1 strain. That was the most common earlier this year. So all of these strains are closely related, and we're seeing kind of a usual pattern that we see with a mix of different closely related strains. Next slide, please. All of these data are available on our website, and we will be showing an updated winter respiratory virus report this fall starting in October that integrates COVID-19, influenza, and RSV data. All right, next slide, please. And let's skip that one and go on to talk about H5N1. Next slide. And next slide. All right. So So far, there have been 5 reported cases of human infection with influenza A H5N1 in the US since 2022. All 5 of those cases in humans have been in people who have been exposed to infected livestock. 4 of the cases have been exposed to dairy cattle in 2024. All 5 have had mild illness, with conjunctivitis being a common feature. All have recovered and no human-to-human spread has been identified. CDC continues to assess that the risk of this virus to humans is low, and the primary concern is that with spread in dairy cattle, there's been increased opportunity for human infection and associated risk of reassortment or mutation to a strain that could spread more easily between people or cause more severe disease. So we're really working to diminish that possibility. There have now been 140 infected dairy herds identified in 12 states. So that's 2 more herds since I made these slides last week. So we are continuing to see new dairy herds be identified in other states. There have been no human or bovine cases identified in California. Next slide, please. However, we have seen H5N1 in California in domestic and wild birds across the state since 2022. And these maps show where in California those identifications have been. Next slide, please. We do have testing for influenza A and H5 specifically in California through the wastewater scan program that is being partly led by Stanford University. Next slide, please. And so far, there have been 7 states. Can we go back one? Great, thank you. So far, there have been 7 states with reported H5 detections in wastewater, including California. The California detections have been sporadic and relatively low concentrations. There have been 4 at 3 different sites. It is notable that there are many more sites with testing for H5 in California than in other states. We have investigated the detections in California, and there is no evidence of human or bovine sources. And the most likely scenario is contamination of wastewater from birds or environmental sources, although this is difficult to confirm. The panel on the right here shows several different ways that H5 could be introduced into wastewater, including dairy discharges, and that has been confirmed in other states, bird intrusion into wastewater facilities, environmental contamination when runoff enters the wastewater treatment facility, and human sources. Next slide, please. With regard to food safety, the California Department of Food and Agriculture has completed 1 round of monthly milk testing at California registered raw milk dairies, and there have been no detections from raw milk in California. FDA is continuing to test pasteurized dairy products, and their research has shown that pasteurization inactivates the H5N1 virus, so pasteurized milk products are safe. Next slide, please. So the greatest risk for infection right now is in people who work closely with infected animals. And people could be infected through a variety of different routes. So our focus has really been on prevention in people who work in poultry and dairy settings. There is information about prevention efforts and worker safety on the CDC website. All right, let's go to the next slide, please, and switch gears to talk about this CDC health advisory that came out on June 13th. So on June 13th, next slide, please. On June 13th, the U.S. Department of Justice announced a federal fraud indictment against a large subscription-based telehealth company that provides ADHD treatment to patients aged 18 years and older across the U.S. So this is primarily a concern for adults with ADHD. And this could impact as many as 30 to 50,000 patients aged 18 and over across all 50 states. This potential disruption coincides with an ongoing prescription drug shortage involving several stimulant medications commonly prescribed to treat ADHD. And this is a significant issue because ADHD is quite common. It affects an estimated 10% of children and about 4% of adults in the United States. Next slide, please. And the primary concern here is that disrupted access to care could cause some patients to seek medication outside of the medical system, resulting in an increased risk of overdose, particularly of fentanyl. So patients who have a disruption in their care may seek medications elsewhere, and a high proportion of counterfeit pills that have been tested by the DEA, the Federal Drug Enforcement Agency, have very high levels of fentanyl. Approximately 7 out of every 10 pills seized from the illegal drug market across a wide variety of different pill types contain a potentially lethal dose of illegally made fentanyl. So this is a significant concern. In addition, persons who have untreated ADHD may be at risk for other adverse outcomes, including social and emotional impairment, increased risk of drug or alcohol use disorder, and unintentional injury. Next slide, please. So the CDC Health Advisory includes recommendations for patients, for pharmacists and clinicians. And briefly for clinicians, CDC recommends that clinicians identify and support patients who may have lost access to treatment, provide alternative therapy or referrals, provide education on overdose risk of pills obtained outside of a pharmacy, and offer naloxone to people who may be at risk. So thank you very much, and I will hand it back to Kim now.
Thanks so much, James. Now I am very pleased to introduce James Tescher, the manager of the Gender Health Equity Section, Office of Health Equity at the California Department of Health. Jason's responsible for statewide grant-making programs focused on lesbian, bisexual, transgender, and queer health equity, reproductive justice, as well as transgender, gender nonconforming, and intersex health equity. Jason also offers strategic leadership in efforts to infuse gender health equity into policies across state government. So Jason, I'll let you take it from here.
Great, thank you so much. I appreciate it, and I appreciate the opportunity to be able to talk with you about this important and kind of timely subject today. So if we can go to the next slide, I just wanted to give everyone an overview. We're going to start off with some definitions and kind of level set. Some of you may be very familiar with this subject matter, and some of you might, some of this may be new, so we want to just do some level setting. I want to talk about the status of gender-affirming care nationally and in California, and then talk a little bit, if we have time, about sexual orientation and gender identity demographic data collection, as it's a pretty significant piece of what the department is doing moving forward. So if we can go to the next slide, I want to just give you just a basic overview of there are, when we're talking about gender, there are 3 dimensions of gender. Some common terms associated with gender include the term cisgender and transgender. Simply put, if you're cisgender, your sex that you were assigned at birth matches up with your gender identity and how you perceive yourself, and it includes gender identity includes your body, includes your identity, and includes how you socialize. Gender is not, as you could see on the slide, binary. It's not a choice. It is certainly not purely biological, and it's not the same as sex assigned at birth, and it's not always outwardly obvious. The right side of the slide there, I just want to make note that sometimes you'll hear the term sexual identity or sexual orientation, um, and and this is about, do I experience attraction? How do I experience attraction, and to whom am I attractive? Sexual orientation is not a binary. Again, it's not a preference. It's not solely someone's dating history, and it's not solely about sexual attraction, and it's, again, not always outwardly obvious. We can go to the next slide there. So we're going to start talking about gender affirming care, and I just wanted to pull this slide up so that we're all starting from the same place. Age appropriate care, that it's medically necessary for the well-being of many, not all, transgender, non-binary, and gender expansive people who experience symptoms of gender dysphoria or distress that result from one's gender identity not matching their sex assigned at birth. Go to the next slide. With gender affirming care, our treatment goals are really to manage dysphoria. And that dysphoria comes in many shapes and sizes for people, primarily falling into these categories of social dysphoria, where the discomfort with presenting socially as your birth gender, your body dysphoria, discomfort with your body being of a different gender in which you identify, and discomfort with your mind and emotions not lining up with your gender identity. We can go to the next slide here. And in terms of gender affirming care, what do? Behavioral health, hormone therapies, and surgeries. And I would note that these are the treatment options. I would note that not all transgender, non-binary, or intersex people require any or all of these. Some treatments, some treatments involve hormones alone. Some treatments involve behavioral health alone, and so it's a mix and match. And it really is about what you, as a physician, work with your patient about what's best for their care. We can go to the next slide. Gender affirming care is, I want to emphasize this, it is life-saving. It is medically necessary, and it is evidence-based. We go to the next slide, please. Most of, and I always put this one up because I think it's important to note that gender affirming care, most of healthcare has nothing to do with being transgender, but being transgender has everything to do with your healthcare, and it impacts people's ability and willingness to develop relationships and trust medical providers. And you all know that the relationship you build with your patients significantly impacts their willingness and ability to seek care when they need it. And this is just something that we note. It used to be, it still is in a lot of cases, but it used to be much more prevalent that transgender people would be turned away from the emergency room, or transgender people would be denied care simply because they were transgender, and it is something that is significant and has an impact, and is very much something that we think about when we are looking at this from a health equity perspective and public health. We go to the next slide, please. So the gold standard for, and unfortunately it looks like maybe there's, oh, there you go, thanks. Just a little information. The gold standard for treatment of gender dysphoria are the World Professional Association for Transgender Health Standards of Care, and version 8. And they are internationally recognized guidelines for best practices, and a very, very useful tool. And I'm also going to point out the next slide is also a very useful tool, something that is unique in the country that we have right here in our own backyard in California. If we go to the next slide, is there is a program called TransLine. It's a warm line where you can call Lion Martin Community Health that's based out of San Francisco, and they will be able to answer questions for you and get back to you. And these are oftentimes clinical questions about hormones. They are sometimes questions about coverage, but this is physician to physician conversations about care for transgender and gender diverse folks. That's a really great resource. And I think the next slide just gives you kind of just the big picture concept of the support for evidence-based guidelines for gender-affirming care. And as of June 30th, over 30 major medical associations and leading world health authorities have issued public statements in support of healthcare for transgender youth and adults. It includes the AMA, it includes the APA, American Academy of Pediatrics, and the World Health Organization. If we can go to the next slide, I think we're going to get into a little bit here. Now that we kind of all have a baseline, get into where we're at from a policy perspective. And I want to emphasize that this is from a policy perspective. The evidence-based for gender-affirming care only really continues to grow as there is more and more funding for research and more attention paid to it. This is a policy shift in the last few years, not a shift in our scientific understanding or our understanding of the benefits of gender-affirming care. 25 states have enacted laws or policies limiting access, and in this case, limiting youth access to gender-affirming care. 39% of trans youth live in a state that has enacted a law or policy that limits their access to care. That means that 39% of transgender, gender diverse youth live in a state where decisions are decisions between a physician and the youth, or decisions between with their parents, has been interrupted by policies. 23 states impose professional or legal penalties on healthcare practitioners that provide minors with gender-affirming care. And one of the things I know, we focus a lot on youth, and that's because that has been the focus of efforts to roll back care for youth. Most attacks on gender-affirming care for adults take the form of rollbacks or fighting against non-discrimination protections in state law or as part of the Affordable Care Act. And so there's not yet a whole lot of folks of policy of laws being proposed to just get rid of gender-affirming care or to ban gender-affirming care for adults, but there are quite a lot of the way that this is being done now is to roll back coverage for that care. Let's go to the next slide. So I want to show you just two things. This is the ban on, this was in 2021. This is what the map looked like. The orange states are states that have bans or restrict best practice medicine for transgender youth. Bans on that best practice medical care represent one of the most extreme and coordinated political attacks on transgender people in recent years. These bills target transgender youth by blocking their access to best practice medical care that is backed by years of research and endorsed by those organizations that we talked about moments ago and other leading health authorities. And these bills not only display a fundamental lack of understanding of transgender children, but they also ban access to medical care, often by criminalizing either the doctors or even the parents of transgender youth seeking best practice medicine for children in their care. We go to the next slide, please. And this is what 2024 looks like. I've already kind of stated the statistics about how many states are moving forward. You will note here that there are a number of states that are considered kind of shield states and have taken a proactive approach, including California, to protecting access to transgender health care. If we go to the next slide here, and this is actually a duplicative. So let's go ahead and go to the next one. And I wanted to point out, I already mentioned 39% of trans youth live in states that have passed bans on gender-affirming care. But this continues to escalate as Oklahoma, Texas, and South Carolina have considered banning care for trans people up to 26 years of age, and several states prohibit public funds from being used to provide transgender care for anyone. We can go to the next slide. So, and by preventing doctors from providing this care or threatening to take away children away from parents who support their children in their transition, these bills prevent TGI youth from accessing these medically necessary, safe healthcare backed by decades of research and supported by every major medical association, representing over 1.3 million US doctors. We can go to the next slide here. In the United States Transgender Survey in 2022, 47% of respondents thought about moving to another state because their government considered or passed laws that target trans people for unequal treatment. And 5% actually moved. And I would note here that this is this is not just about whether states are able to ban care, but it is about the fear that patients feel in, well, and this is absolutely in what we talk about when we talk about people not wanting to get not wanting to be active in seeking healthcare or delaying healthcare because they only want to go if they to see their doctor if they want to in these kinds of climates, and it leaks in here in California. If we can go to the next slide, please. And these attacks on transgender people impact their health. We see stories pretty consistently about the Texas Attorney General's office seeking state data on transgender Texans. We see stories about teens and their parents moving states in order to in order for them to grow up in a place where they're accepted. And this is challenging. And if we go to the next slide. And like physicians, that you are unfortunately in the middle of this all. As providers, the relationship you build with your how important that is, but you also have to keep an eye on what's going on externally. If we can go to the next slide there. And over the past, I keep emphasizing this, but over the past few years, as these attacks have ramped up, the AMA and other organizations have publicly talked about their policies, and in order to provide backup for physicians so that you can do your job. One of the nice things is that we live here in California, and we are not just taking measures um, to protect the gender affirming care, not just protect trans teens and youth, but also and transgender adults, but also to expand access in California. And if you go to the next slide, you'll see a quote by Governor Newsom. I think this is in him signing one of the pieces of legislation we'll talk about in just a moment, um, and about no one being prosecuted for getting the care they need, including gender affirming care. Parents know what's best for their kids, and they should be able to make those decisions around the health of their children without fear. I'm just going to give you. We only have a couple more minutes left, so I'm just going to give you a little bit of an overview of the history in California. This isn't something that support for and the changes that we've seen in healthcare for transgender, gender nonconforming, and intersex individuals isn't something that has just happened over the past few years as we've seen attacks. There have been organizations and groups working on non-discrimination in healthcare for, as you can see, almost 20 years. The first major landmark piece being AB 1586, which meant in 2005, which said that you're not allowed to discriminate based on someone's transgender status. That was turned into an official regulation in 2012 under Insurance Commissioner Dave Jones, who I worked for at the time. And further down the line, you can see kind of how we've expanded care in California and protected care in California. And that includes gender affirming care being part of Medi-Cal. It includes AB 959, the LGBT Disparities Reduction Act, which mandates the collection of sexual orientation and gender identity data by providers, and other non-discrimination acts. And what I will mention the most recent couple of ones. In 2017, the Gender Recognition Act signed into law makes it significantly easier for transgender people who are living in or born in California to obtain identity documents that reflect their genders. It makes California the second state in the country to offer a standard path to obtaining a non-binary gender marker. Excuse me. Pardon me. On state documents. Pardon me, just a second. Oh dear, sorry. SB 107 bars doctors from releasing medical information to authorities in other states investigating families of transgender children for taking them to providers for gender affirming treatment. And it also prevents law enforcement agencies from arresting people for violating other state laws regarding gender affirming care. That said, I think that is all the time that we have, and so we're not going to get to touch on sexual orientation and gender identity data collection, but we're happy to return and have that conversation with you at a later date. So thank you very much, and pardon my something caught in my throat. Thanks.
So sorry, and I guess it was a good time to end your talk. We'll give you a minute to breathe. That was an incredibly comprehensive view of what's been going on both nationally and the state in this important area. I'm going to ask James to come back on camera. James, if I can ask you a couple of questions, so we can give Jason a couple minutes to get his throat. Good.
I'm good now. Thanks.
Thanks. Hi, James. So James, we did have a couple of questions for you today. And one of them is, how widely, can you just tell us, is the wastewater surveillance happening for COVID? Is it happening in all counties in the state, or is that a select sampling?
It is a select sampling. It's not happening in all counties, although we have tried to diversify the types of sites that we're sampling in as much as we can. There is some fluctuation over time. Some facilities come online or go offline, but our goal is to be able to get data from a wide and representative sample of wastewater facilities around the state. And we do work with Wastewater Scan, as I mentioned earlier. We do some testing here in our department, and we have other partners as well that are doing this. So we're collecting data from as many different places as we can.
Great, thank you for that. And for everyone in the audience, apologies, but my internet is going in and out today. So sorry if you can't hear me, if I do disappear from camera, but you can hear a disembodied voice, that's why. And if worse comes to worse, my team will come on and ask some questions that have been coming in. But I do have a question, and my internet went out as you were giving your presentation, James, so I don't know if you answered it, so apologies if so, but one person was asking about how clinicians should think about testing for H5N1, think about when do I test, what is my sensitivity these days for doing that kind of testing, and how do I interpret it, and who do I tell the results to? So even if you talked about that, maybe just go over it again, because I think it's quite relevant right now.
Thank you. No, great question, and I did not cover that. So if you have a patient who has symptoms of influenza, as I mentioned, what we've been seeing in patients with H5N1 is conjunctivitis and mild upper respiratory symptoms. We're particularly thinking about H5 right now because the seasonal influenza is low. And so if you have someone who has symptoms who may have had exposure to a farm, a dairy, a poultry, or to sick animals, then you can contact your local health department for information about how to get an H5 test. There may be some commercially available testing, but local health departments do have access to the CDC test for H5 and can work that out through your local public health laboratory. Certainly, if you have a suspicion, a high suspicion, please let your local health department know, or if you get a positive test, please let your local health department know right away.
Great, thank you. Jason, moving on to you. We had a number of folks from around the state asking, how do I find experts in gender-affirming care in California? It's clearly not obvious. So is there any kind of standard or place that's easy to figure out who should I refer people to?
Well, I think that there's two answers, or a couple of answers here. First of all, the resources that I put up, the World Professional Association for Transgender Health and the Lion Martin's Warm Line, their trans line, it's a great place to start. I would note that most specific treatments for gender affirming care are things that that primary care physicians do for a lot of other patients. And they monitor it for lots of other patients. Hormone replacement therapy is a great example. And there are slightly different, like for example, for estrogen, there's slightly different levels that you look for in a transgender person than you do in other ways. And those are really outlined in the WPATH standards of care. What we want to try to get away from is funneling all transgender people into a particular program as opposed to integrating people into our practices, into medical practices. And so and the part of me, I'm not a physician, but have a partner who is one, and so when we talk about this, um, we talk about just like if I have a patient, if he is a patient who has a cancer diagnosis that I'm not familiar with, and I'm his primary care, I am doing my research and figuring out, and it's the same thing with transgender people. We are, and so I think that the funneling of trans people to very specific areas of treatment, especially stuff that's within a scope of practice of a primary care physician, has a tendency to clog up the system. It creates barriers for additional barriers. And it's not to suggest, of course, that obviously you have to send people out to specialists, but understanding that process is important. So there's a lot of like we want people to be doing this with the people they have relationships with, and then yeah, if that I hope that makes sense.
Yep, I think that's a great perspective. Thanks for that. Can you talk a little bit? This may not be your area of expertise, but I imagine in the advocacy world it comes up. Is gender affirming care, recognizing that's a broad spectrum of care, but covered by insurance, commercial, Medicaid, Medicare?
Yeah, and it's funny that you say maybe that's not your area of expertise, but frankly, I worked at the Department of Insurance for 10 years or for 8 years doing this specific work. So I know way more about insurance than I ever thought I would. As many folks know, in California, the in health coverage is regulated by multiple entities. So there's the Department of Managed Healthcare, there's a Department of Insurance. For Medi-Cal, there's Medi-Cal Managed Care. And all of those in California are required to provide, when clinically necessary, when medically necessary, required to cover gender affirming care. Even in Medi-Cal. And this includes the broad range of treatments. Oftentimes we talk about gender affirming care in terms of surgeries, but we also talk about gender affirming care in terms of um, the reduction of stress that comes with secondary sex characteristics to which you do not uh, uh, doesn't feel like part of your identity. And so even those broad range of surgeries or treatments are absolutely covered, and it is part of California non-discrimination law. And in California in 2011, those regulations that I talked about up front that we passed kind of started a little bit of an avalanche, and they have used those regulations and that language across the country to in states that have adopted them that protect that care, and the federal government also includes it as part of their gender identity protections for in Section 1557 of the Affordable Care Act, which is the non-discrimination section. So absolutely covered. I used to, however, tell trans folk that, great, now we have insurance coverage. It's the same dismal coverage that the rest of us have now. And so it's challenging to jump through hoops to get that care.
Yeah, okay, helpful. We had a pretty basic question, and I know this is an area where you've been working for many years, but for many of us, even the terminology in this area is challenging. And so some of gender affirming care is just acknowledging in our clinics, how do people want to be addressed? How do we ask about this in a sensitive way? I think that's very uncomfortable for many of us who again don't have a ton of experience. So one of the questions we got is, how do I address my patients in the clinic? Usually I say Mr. and Mrs. or Sir and Ma'am. What do I do if I then find out someone is asking to use they them pronouns, for example? It's hard to navigate. So how do we show up for that?
Sure, and there's all kinds of shifts that are going on, and I think that people in the end, um, folks, regardless of their gender identity, just want to have their identities respected. Um, and sometimes respecting people's identities is simply asking, like, how do you identify? And there was a study in an LGBT health uh, 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 journal in 2017 that uh, showed that a majority of clinicians rarely or never talk to their patients about sexual orientation, 55% of them said, or gender identity, 71.9%, mostly due to believing that the topics were not relevant to care, concerns that with making the patients uncomfortable, like you're noting, a lack of experience, and not knowing the appropriate language to talk about the subject. 80% of providers felt that collecting sexual orientation data would offend patients, whereas only 11% of those patients reported that they would be offended, which goes a long way in our thinking about, like, everyone makes mistakes when they're and when they're addressing folks. Sometimes you pronounce someone's name wrong. Um, However, that connection that you can create by helping someone feel seen is so significant to someone's willingness to engage with you on their around their own care. Um, and there are a lot of resources around providing culturally responsive care. And just a simple example is when you, like, if I mess up someone's pronouns, and someone corrects me, I just say thanks. I don't make a big deal of it. I'm like, thanks. He is, and and you don't make a big deal of it. You don't apologize profusely, because that puts a TGI person, like a trans person, in the awkward place of, like, having to forgive you, and that feels weird to people. And you move on from there. And the information that you will get with your patients and the kind of care that you'll be able to provide will so increase by just having will improve by just having that kind of relationship with them where they feel comfortable doing that. There are so many patients who are trans folk, who feel like they have to teach their providers about their care.
Mhm.
Um, coming in with information and showing that you care is really important. So there's a lot there. Sorry, I could go on for a while, because you can do like an LGBTQ 101 around language, and in fact at the department we do that for multiple audiences. So
Mhm. Okay, great. Sounds like there are lots of resources. And in fact, one person was asking the details of the trans line, for the phone contact and details again. So we'll make sure that everybody has that, and we'll send that out after our talk today. But one thing that folks are asking is, this is an area where, Jason, you've said it, there's decades of data, but it's still relatively new in the arc of medicine for those of us. Those of us are old like me, didn't learn about it going to medical school, et cetera. And I'm quite sure, even though there's a lot that we know, there's also a lot of questions that remain unanswered, and research that needs to be done. So I'm curious about two things. One is, when you talk about the best practice medical care, for example, by the World Professional Association of Transgender Health, et cetera, how have these recommendations evolved over time? Are they still evolving as we're getting more research and thinking about, the impact of children over a lifetime, because children haven't been receiving this kind of hormonal care at scale, et cetera. So can you talk a little bit about the evolving of our scientific knowledge?
oh, sure. It's the evolving of the science, but it's also the evolution of our understanding of gender.
Mhm.
Um, and I want to say that these were originally called the Harry Benjamin guidelines for transgender health, like way back, I think maybe in the 90s. in the early 90s, and it has transformed into WPATH, and there is in fact also a US PATH group, and the I guess I guess all I can say is that with each iteration, for example, with the iteration that went um, from six to seven. It used to be called gender identity disorder. So it used to be labeled a disorder. It's moved to gender dysphoria. And while they haven't solved all the problems of pathologizing someone's gender, they most certainly have um, they most certainly have identified that it is the external forces, much like minority stress, that have the most impact. So by making it, on patients, so by making this gender, as I put it earlier, the management of gender dysphoria, as opposed to the treatment of gender identity disorder, they've taken the responsibility off of the individual, and so that was there's a big conceptual leap, but also in addition, as they make these iterations, the science has changed and impacted it and changes, and so they've definitely this is a group that takes several years for each new iteration, and they're fascinating to watch and fascinating to watch them interact with community as they do so.
Yeah. Thanks. And I will note that we were hoping to feature a physician who's involved in this care because Jason knows a lot of this, but we just wanted to give that physician's point of view, and we're unable to find someone who's available this month, but we'll do that in a future talk so we can get more deeply into those issues. James, I want to ask you a question that we had from the audience. Someone was asking about what's going on with Mpox and the vaccine availability. In particular, can healthcare workers receive it now? So maybe a quick comment on that.
Yeah, thank you very much. So we are seeing some increases in Mpox in recent weeks. So Mpox is definitely still an issue in California. And we definitely want to encourage anyone who may be at risk for Mpox to get vaccinated. The vaccine is available. It is available in a more commercial settings, and I don't have any specifics about the details of how easy it is to get, but uh, um, it should be widely available. Now, whether it is or not, I can't speak to. We are continuing to see consistency in the groups of people who are most at risk for Mpox. That is primarily amongst men who have sex with men. And we are not seeing a significant spread in healthcare workers or transmission in healthcare settings. That continues to be quite rare. So I don't believe that there is a specific indication for persons who may be at risk, primarily because of healthcare work. On the other hand, people may have other risk factors. People who are healthcare workers may have other risk factors that would be appropriate for receiving the Mpox vaccine.
Great, that's helpful. And oh, go ahead.
Just one other comment. We are continuing to see only the clade 2 Mpox in the United States. There is a large outbreak of clade 1 Mpox in the Democratic Republic of Congo, which tends to be more severe and have some different transmission patterns, but that is still restricted to the DRC.
Okay, great. And one other question's for you, Dr. Watt. Anything new regarding the measles outbreak in Santa Clara? We had someone.
I am sorry, I can't speak to that.
Nope.
If I could, just to go back to an earlier question and clarify about H5 testing, providers who are concerned about H5 can begin with an influenza test. And because H5 will result in a positive influenza A result. And oftentimes what we'll see is that there will be a positive influenza A result, and when subtyping is done, it will not show up as either H3 or H1, and that's a sign that additional testing in the public health setting is indicated.
Okay, great. Okay, I'm going to end, Jason, with a question for you that I suspect would require a much longer answer, but recognize we only have a few minutes and I need to close it out. And I don't want to give short shrift to this, but the sort of elephant in the room to some extent these days is the report to the NHS in England by Dr. Hilary Cass. And just wondering how that is impacting conversations in California and the US, and or if you have any just quick conversations or comments about
I I think that there's two things, and there was recently a Yale journal review about looking at their methodology. There's a couple of things. The political attacks on gender affirming care for youth, the folks who are doing that are going to use whatever materials they have available to them to support their position, and they're not entirely concerned about the validity of that data. So I just wanted to throw that out first. Second of all, I think that my thinking about the Cass report is for those of you who don't know, like the Cass report determined that providing hormone puberty blockers for youth didn't reduce gender dysphoria. And I think that the issue with their methodology is like that's the wrong question to ask, because puberty blockers are not supposed to reduce dysphoria. They're supposed to be for keeping dysphoria from getting worse, giving youth and teens enough time to delaying puberty and giving them enough time so that if later on down the line they decide that they're transgender, or and they want to transition, but they haven't developed those secondary sex characteristics that can, in many cases, be extremely that can be even more that can have an even greater impact on dysphoria than say, for example, genital surgery, or what genitals they have. And so I think, frankly, the Cass report was asking the wrong question. This is not supposed to be a cure. This is supposed to be a delay so that folks can make up their own minds without significant medical issues requiring much more drastic interventions in the future.
Okay. Much more to say here, but I really appreciate you both being here today so that we can begin to address this important topic. And I just want to remind everyone who's here today, first of all, that we appreciate you. Send out the recording to any colleagues you're interested in. Please continue to send us ideas for topics that are urgent and interesting to you. Don't forget that survey that you'll get at 5 o'clock today, so you can attest to your attendance and get your CME certificates. And just to know that our next session will be on a different date. We usually do the second Tuesday, but please come, because we're doing on Tuesday, August 20th, discussing the rise of valley fever in California. So thinking about coccidioidomycosis, which is going to be super interesting and important. We also have great events coming up this week, like the Health Equity Leadership Summit and the Medical Group Advocacy Symposium. So cmadocs.org/events. Hope everyone has a great day. Thank you again, Jason and James, and we'll see you soon.